So, welcome everybody to Pediatric Grand Rounds. I'm Suzanne Mazo, Director of Continuing Medical Education here at Seattle Children's. And from here, I will turn the virtual microphone over to Dr. Leslie Walker Harding, who is going to introduce our speaker. Thanks so much.
Thank you so much, and good morning, everybody. I'm so thrilled to be able to introduce Mr. Mark Del Monte to those of you who aren't familiar with him. I've actually known Mark for I think the full 15 years that he's been at the AAP. I first met him when he was being a great advocate for us at the Society for Adolescent Health and Medicine, and he was such a dynamic person. You just knew that he was going to continue to, move and shake and make a difference. He has really done that over the 15 years, and I was so excited when he was selected to be the CEO and executive vice president of the American Academy of Pediatrics. He continues in really quite interesting and tumultuous times over the 15 years to help us really improve the well-being of kids, really get that before the legislature and so many different ways from state to national. He's really helped pull things together. So I'll read his bio. Mark leads a strong, Mark serves as the CEO and Executive Vice President of the American Academy of Pediatrics. In this capacity, he leads a strong chief executive team for the organization, which serves 67,000 pediatricians, pediatric medical subspecialists, and pediatric surgical specialist members. Prior to this role, he served as the AAP's Chief Deputy and Senior Vice President for Advocacy and External Affairs, where he directed the organization's communications, public relations, and advocacy activities. Prior to joining the AAP in 2005, Mark served as the Director of Policy and Government Affairs for AIDS Alliance for Children, Youth, and Families, a national organization advocating for children and families with HIV and AIDS. Before moving to Washington, D.C., he worked as a lawyer in his home state, our home state of California, providing direct legal services to HIV-positive, low-income children and families. And he received his law degree from the University of California, Berkeley, with a bachelor's degree in Gonzaga University. And I wanted him specifically to come just at this time. It's not a coincidence that today is the day our King County ballots will be coming out. I thought that given all the information he has on what we need to be looking at in the future, how we can continue to be advocates for children nationally and locally, that this was the perfect time as we start voting to really have him come and give us some of the thoughts that where AAP is looking at, and where we should be looking at as we want to be the best advocates we can as we move into a new election cycle. So, Mark?
This is fun. We have been, I've been looking forward to coming and seeing you all for a long time. I would love to come and see you in person whenever that is safe to do. It's a standing offer to come and be with you and the marvelous faculty. Washington State, I went to Gonzaga University, and so I have a soft spot for Washington State for sure. Go Zags. And we have enormous leaders of the AAP, enormously impactful leaders of the AAP from Washington State. Of course, our immediate past president, Kyle Yasuda, is from Washington. You have a very dynamic chapter in Washington State led by the chapter president, Elizabeth Mead. And in fact, I just want to plug, tonight they're doing a nice webinar on the 2021 legislative agenda in Washington. And so if you don't get enough advocacy this morning, there's more that you can get tonight with the Washington chapter. And then, of course, the district chair for District 8, where Washington State is Martha Middlemist from Colorado. So there's lots of exceptional AAP leaders around to support the work of your faculty in going forward. So what I'm going to try to do this morning is mix a little history and a little politics and a little policy to sort of set the stage for, I think, where we are at this incredibly consequential moment in time and how we should be thinking about the role of pediatrics as a part of it. And so if you don't mind, I'll go backwards a little bit in history and begin there and then move us to today. This year, we are celebrating the 90th anniversary of the American Academy of Pediatrics. It was in July of 1930 that a group of pediatricians got $12 together and went to the Secretary of State in Illinois and founded this new organization, an organization of pediatricians with a mission to further child health and to take care of the professional needs of its members. It was a medical society unlike any other, and it came out of a specific moment in time that sort of set the DNA of the AAP that has lasted us now for 9 decades and actually gives us a clear direction and vision for the future. And so, to understand where we are today and where I think we're going, it's good to understand where we began a little bit and what set us in motion. So our founders actually were mid-career pediatricians in the First World War and served in Lyon, France, and Belgium with the American Red Cross. Dr. Clifford Gruely actually ran a children's hospital in France during the war. They also were mid-career physicians in the pandemic of flu in 1918. They were operating in the context of widespread post war poverty, public health that was nascent, and widespread disease with limited armamentarium. And so, this was the context in which these pediatricians decided that the world needed to change. Something had to happen in order to improve the lives and well being of children. And so they founded the American Academy of Pediatrics to drive those changes forward. This is a uh, agenda for the very first annual meeting of the AAP, June 12th and 13th, 1931. And there's some very interesting features of it. If you'll indulge me, I'll just point them out. First of all, the meeting was very short. It started on a Friday at 8 p.m. and ended on a Saturday at 2 p.m. And so that was a whole board meeting. But if you look at the agenda, if you can see it on your screen, there were already regions. So this notion of chapters, this sort of geographic representation across the country for the academy, and then a series of committee reports. This is the very first meeting. There was a report of the Committee on Medical Education, a committee on hospitals and dispensaries, a committee on relation to the section of diseases in children and the American Medical Association. And then over in the far panel here, you see advocacy immediately as part of the engagement. Report of the Committee on Relation to the White House Conference on Children, report of the Committee on Relation to the Academy to Philanthropic Agencies and Welfare Workers, Committee on School Health and School Health Education, the Committee on Mental Hygiene. So from the very beginning, emotional and behavioral health, looking outside the clinic into the school systems, engaging in advocacy, it literally was all there in the very first meeting of the Academy of Pediatrics. One of the outputs that was happening at that time and their engagement with the Hoover administration, it was a progressive era, and there were these burgeoning notions of public health. So working closely with the White House and then President Hoover, there was a conference on child health and protection. And out of that conference came this document that's called the Children's Charter. This is it. This is the entire charter. And it lays out in very simple but clear terms the rights of the child as the first rights of citizenship, and that the White House pledges itself to these aims for the children of America. I'm going to point out a couple of these provisions just because they're so inspiring. So the first one here, number 6, for every child, health protection from birth through adolescence, including periodical health examinations and, where needed, care of specialists and hospital treatment, regular dental examinations and care of the teeth, protective and preventive measures against communicable diseases. So remember, this is 1930, and they're talking about health promotion, anticipatory guidance, sort of the notion of what we would now call bright futures, that there needs to be periodical health examinations, already thinking about dental care and prevention against communicable diseases. For every child, a dwelling place, safe, sanitary, and wholesome, with reasonable provisions for privacy, free from conditions which tend to thwart his development. Social determinants of health here, safe housing, uh, uh, sanitary living conditions, clean water, all there right in 1930. For every child, education for safety and protection against accidents to which modern conditions subject him. So, injury prevention has always been part of the AAP. For every child who is in conflict with society, the right to be dealt with as society's charge, not society's outcast. I think this is a beautiful discussion of juvenile justice. So, for every child who is in conflict with society, to be dealt with as the charge of society, not as the outcast. And for every child, these rights, regardless of race or color or situation, wherever he may live under the protection of the American flag. Obviously, this calls out our work in immigration and that every child living within our borders deserves care and our best care and treatment. And this is all right here in 1930. And so these were the kinds of issues and goals that set the DNA of the AAP going forward. So, in summary, it was the beginning of a new century. There was growing awareness of what we would call social determinants of health and public health today. The founders founded the academy in this progressive era where infant mortality was way too high. Child labor laws were just getting rolling. Public health was a concept. World War II and the Depression was World War One and the Depression was affecting everything, and they were beginning to use the tools of public policy. The Shepard-Towner Act, creation of the Children's Bureau in the federal government, the White House Conference on Children, to begin to affect change at the public policy level. And so I think in the midst of all of that, we have some context for all of the difficulties and challenges that we are facing today to give us some framework and some grounding in how to think about the challenges that we face. So fast forward then, in 2016, we issued what's called the Blueprint for Children. This was before the last presidential election and laid out our agenda for kids for the new administration. This went from soup to nuts across the federal government and all of the federal agencies, and laid out in very specific terms what we think would happen. Most recently, we have been issuing a different kind of document, and that's the advocacy report of the AAP on COVID-19 response. We have been focused over the last few months, obviously, the last 7 or 8 months, on all of the aspects necessary to respond effectively to COVID. So, as I mentioned, 2016, let's go back there to give us context. You guys are getting your ballots today. And so it was November of 2016, November 8th specifically. There was an election, and Donald Trump became the president of the United States. He won with a very substantial electoral vote, 316 electoral votes compared to Secretary Clinton's 232. But Secretary Clinton won the popular vote by a substantial margin, by several million votes, actually. But in our system, the Electoral College wins, and so Donald Trump became the president of the United States. Thinking about this dichotomy, this mix between the popular vote and the electoral vote, I think is instructive for how we're thinking about where we are at this moment in the election today. So this is I just pulled these yesterday. This is the Real Clear Politics poll of polls to tell you the difference between where Joe Biden, former Vice President Joe Biden, and President Donald Trump are polling in the election right now. So what Real Clear Politics does is take all of the national polls, average them together, and get an overall average. You can see that right now, former Vice President Joe Biden has a 9-point lead over President Donald Trump in the national polls. That lead has sustained over time. You can see that the real divergence began about the end of summer, midsummer, end of June, beginning of July. The polls widened at that point and have maintained pretty significant variance all throughout the summer. And now, as we go into the final weeks here, the election is 3 weeks from day before yesterday, Tuesday. And so we're in the home stretch. If the trend line here is pretty flat and pretty significant difference for Joe Biden. And I think the way to think about these numbers, you hear these polls in the news every day, and you should correlate these polls to the popular vote numbers. So this is the way to think about what's the total number of the country thinking in the total across the total of the populace. This is not related to the Electoral College. And so you can be very substantially ahead in popular vote numbers or in public opinion and still lose the election. So I just want to correlate in your mind the popular vote to these national poll numbers. So then let's look at the Electoral College map. Right now, if you look at states that most pollsters are looking at and calling, former Vice President Joe Biden has 216 Electoral College votes wrapped up, President Trump 125. The fascinating thing about where we are 3 weeks out from the election is the number of states on this map that are still toss-ups or gray in the color that you see here. Particularly for President Trump, states like Florida, Texas, Arizona, Georgia should not be gray at this point. If you look at historical voting patterns, they were certainly in his camp by this point in the election in 2016. And so the idea that states like Iowa are still a toss up at this point shows real weakness, unfortunately, for the president. He is having to hold ground that should be sort of part of his base group of electoral votes while he's working in the states that we always talk about every 4 years: Michigan, Wisconsin, Ohio, Pennsylvania, et cetera. And so he's got some weakness within his own typical constituency states to make up, in addition to those battleground states. Very interesting, this point out. And if you're Joe Biden, you're starting to feel slightly optimistic. If you're President Trump, you've got a lot of work to do to get your votes back in line here in the Electoral College. One measure that I like to look at there's all kinds of measures that people use to sort of try to prognosticate about the country. But one that's pretty solid is the right track, wrong track polling. And they ask Americans in a very longitudinal way, do you think the country's on the right track or the wrong track? And that indicator is pretty consistent over time in whether the country's in a flipping mood. Are we ready to flip the White House to somebody else? And so right now in 2020, about 29% of Americans think that the country is going in the right direction, and about 65% of the country thinks that America is on the wrong track. And you can see where these numbers split and then what happened in the subsequent election for president. And so this is a danger sign for the incumbent, obviously, as we go forward. So going back to 2016, then, the priorities that we articulated for the blueprint were immunizations, access to health care and health coverage, immigration, nutrition access, child welfare issues, big, huge categories of child health and wellness. As we've been thinking about COVID-19, obviously our advocacy has been much more focused on supporting frontline pediatricians, improving health coverage, especially in Medicaid, strengthening existing systems and programs to respond to COVID-19, and bolstering support for children and families in the United States and around the world. Specifically, what that has meant for us is that we have to do much more work to stabilize the existing healthcare delivery system for children by addressing the financial hardships that came immediately in the middle of March of this year and sustained deeply, and we're not nearly out of the woods at all. Physician practices need help. Health systems need help. They are starting to recover, but too slowly, and the damage is deep and lasting. Medicaid is a big part of that. And so as states are already experiencing recessions, we know that Medicaid is a counter-cyclical program. When recessions are happening, Medicaid enrollment goes up. And so we need more dollars from the federal government to shore up states who are having shortfalls as a result of the recession. Vaccine issues have been predominant in this. We have seen very sharp shocks in vaccine administration rates. We need to get those back up, particularly as kids are getting back out into the world. and improving vaccine confidence if we're ever to be ready for a COVID-19 vaccine. And the basic needs of families are at risk here. We have seen survey data that we can be confident in that food insecurity and insufficient food is rising across the country. Housing is becoming at risk, particularly as protections around evictions start to decline. The healthcare system is practicing in a context of limited PPE and limited information about the pandemic and access to appropriate therapeutics. So what we don't need is a whole bunch of litigation about that. That people have done the best they can. So we need some liability protection for frontline physicians who have been heroic without sufficient equipment and other things. We need to stay involved in the World Health Organization and participate in global health. We need to worry about our IMGs and other visa holders who are having trouble. They're very essential to the healthcare system. Immigrant physicians and others who are here studying and learning and practicing on visas. Children who are in congregate living, like juvenile justice, are at high risk for contracting COVID. And of course, the whole issue of schools and returning to school safely, et cetera, critically important. That leads us to the election. In order to accomplish our advocacy goals and our public policy goals, we need politicians and elected officials and public policy makers who care about what we care about. And so this election is so consequential to the health, safety, and well-being for children, climbing out of the pandemic, but also going into the future outside issues related to SARS-CoV-2. So we have produced a new election guide for our members that focuses on equity and that reaches out beyond pediatrics to have new partnerships to mobilize people to vote. We have put together a toolkit, Vote Like Your Health Depends on It, and encouraged people to find out if they're registered, and if they're not registered, to register and vote. The digital toolkit has all the key child health issues, what's at stake for children, and registration resources, tools for you to use to help encourage families to vote in these last few weeks, sample social media messages, and resources for all of our chapters. This is a screenshot of the Vote Kids page. For every one of the key issues that I'm going to talk about in a second, you can see here the child health issue is identified, and then you can click on it and get more information on each one, including how are children affected, especially in terms of health equity, what elected leaders can do about it, what are key AAP resources we have for you, and if you have candidates and virtual town halls and the like, questions that you can ask candidates. The website is right there, aap.org, Vote Kids. So what's at stake? I've spoken a little bit already about COVID-19, all of the issues related to that: access to healthcare, Medicaid coverage, nutrition, and resources for schools so that kids can return safely. Racism, to reduce the disparities that have resulted from long-term systemic and institutional racism that has impacts on child health. We have clear policy on this, and so there needs to be immediate efforts to build anti-racism strategies into housing, education, the healthcare system, policing and incarceration, etc. We believed that racism has long-term effects on child health before the killing of George Floyd. And the killing of George Floyd only exacerbated the concern. And of course, as you know, it sparked a reckoning across this country and an important and overdue dialogue about the role of policing in communities of color and in police violence in particular. AAP did not stay on the sidelines of this. We do have a policy statement on the impact of racism and child and adolescent health. It builds on our previous statements about social determinants of health. So the way that AAP articulates this is to get it out of the politics and get it out of the sort of back and forth debates about it, and to just to identify it within the paradigm of social determinants. Racism is a core social determinant of health. And if we think about it in that way, we can attack it in the way that we can attack other social determinants. So, like food insecurity or housing insecurity, the idea that zip codes drive health outcomes, we know how to think about these things. And as we add racism to that list, we have tools in our toolbox to address that as well. And of course, the intersectionality of everything that we knew about systemic racism and poverty, we now know about the intersectionality of COVID, of racism, and of deep child and family mental health and behavioral health concerns. There was a pre-existing need for high quality resources for families on emotional and behavioral health before the pandemic, and before the killing of George Floyd, and certainly now with COVID and its disproportionate health impact on historically underserved communities of color. It exacerbates pre-existing mental health conditions as well. And so now we have to tackle this tangled difficulty all together and all at once, and work on that across the whole of pediatrics. We were so pleased at the national conference and exhibition that we had last weekend. The content on racism was filtered throughout all aspects of the meeting. Our PEDS 21 was focused on the topic. Our keynote speaker, especially Ibram Kendi, Professor Kendi, and others, really sort of mainstreamed this notion that racism is a part of pediatric care, and that as pediatricians and professional healthcare professionals who care for children, it has to be understood, and that the individual expertise and awareness of those issues for yourselves and how it plays out in practice is part of learning in the profession of pediatrics. And so we are happy to provide medical education on that as a beginning of a much larger conversation that needs to take place over time about racism in the healthcare system, as well as the structural racism that we talk about in communities. What's at stake? Immigrant child health. Support the health and rights of immigrant children and families, and ensure all who arrive at our border are treated with respect. This is not just an altruistic concern. We have clear data that that Black and brown kids have less access to health insurance, and that Black and brown kids are poorer than white kids and need Medicaid at higher rates. So what we're looking at here is a percent of the total US population and share of children covered by Medicaid by race and ethnicity. And what you can see is that the number of Black and brown kids are, as a share of all children with Medicaid, are higher than the total population, and disproportionately higher than white kids. So this is just access to care, and this disparity is right in front of us. Climate change and clean air, obviously, we look at the West on fire and hurricanes in the Gulf Coast. Clean air, clean energy, clean water. These are child health issues that we need to focus on as well. Gun violence. Gun violence has been out of the headlines because there's been so many other things in the headlines, but the data continues to be very clear that there's far too much morbidity and mortality associated with guns in children. This is increasingly a story of youth suicide by gun, and we have to continue to work at this. CDC dollars are flowing, and we're starting to see gun violence prevention research being funded again, and that research is just getting rolling. We don't have data from it, obviously, since it's new, but we need much more substantial federal investments in prevention research. And healthcare coverage and access. We were worried about this before the pandemic, and of course, the pandemic has just highlighted for us all the gaps in the existing healthcare system. This is a chart that I like to show about the future of pediatric practice post-pandemic. Because healthcare professionals jumped into healthcare in such a robust way, it gives us an opportunity to reclaim the authority in designing the healthcare system that comes out of this pandemic. We now know for sure, if we didn't know before, that the system of high volume, fee for service based, in person meetings financed by third party payers, whether public or private, collapses immediately in a pandemic like this. That if you have fee for service, inpatient visits in the outpatient side, driving financing, and you have procedure based or even elective procedure based uh, uh, inpatient drivers for all of the revenue in acute settings, and those things evaporate, then the healthcare system collapses and payers do just fine. This is backwards. This is inside out and upside down. And so we need to think about a healthcare delivery system that makes the drivers work for families. If you put families in the center, then you can easily develop family focused healthcare systems that are deeply connected into the communities in which they function. And so healthcare is not just a clinical experience in the clinic, but deeply connected with team based care outside the clinic with social services and all of the other schools and supports that kids and families need, that's a seamless partnership that is paid for, that those partnerships are financed. It's not something that you do on the side or outside of clinical care, that we can deeply increase the way that we use data, and that the evidence base for interventions is augmented by these systems and not in spite of it. And so healthcare in which we know what the interventions are because they're data driven. That means much more investment in pediatric research, in NIH research focused on kids, and in health systems research so that we know about how to provide systems of care that work for children and families. That's data driven. That data is also, of course, going to be driven by what's going on in the community. So, how do we take equity and social determinants of health and inform healthcare systems to make those work for kids? I think we can no longer deny that structural and institutional racism result in worse outcomes for children of color. I think that the evidence base is sufficient and growing that that's the case. So, if we know that that's the data, what do we need to do to change the systems in order to make those outcomes different? That's true of race and ethnicity, but it's also true of all sorts of other things: poverty and zip code and access to good schools. All of that determines outcomes for kids far beyond what often can happen in just the medical setting. So, thinking about equity and social determinants as part of it. In addition to data, we have all sorts of technology. So the innovation that occurred for pediatrics in the beginning of March or middle of March, beginning of April, was astonishing. You had practices who had no history of telemedicine whatsoever rapidly adopting telemedicine, either through telemedicine platforms or just calling folks or talking on FaceTime or checking in with people by phone or Zoom or something else. We now know that telemedicine or telehealth approaches have to be part of pediatrics, and so we determine what does that look like, and what is best. What are they best suited for, and what are they not suited for? How do we integrate that technology into the basics of it, both in the inpatient setting or surgical follow up or chronic care of children or primary care? I think telemedicine is here to stay, and so we have to figure out how to right size it and make it work. And certainly, we have to make sure that it gets paid for, so that we can implement it appropriately. That's also true of AI and this sort of cloud-based power of computing that we can look across data sets and derive much bigger understandings and meaning. We're very excited about this potential at the AAP, which is why we are building the Child Health Data Registry. We are in the middle, at the very early stages of developing a longitudinal EHR-based health data registry that will receive EHR data from our members and from institutions, gather that up and make it searchable so that we can, one, help our individual members and institutions use our data for quality metrics so we can make sure that the chip record data set evidence base is there for you, pay for performance measures, see how you're doing related to other practices in your area, other hospitals in your area, your region versus another, all of that. And then if we can get a big enough data set into the registry, we can start asking questions about therapeutics and align with immunization registries or school attendance registries so that we can see what results in school days lost, et cetera. The power here is very exciting, and there's great optimism about our ability to employ these things. So stay tuned. You're going to hear a lot more about the Child Health Data Registry as we start to get that built into the future. And we're going to need partners all over the country in making that a success, and we'll be coming to you about that certainly much, much more into the future. And then, of course, the pandemic. I think we have learned very quickly that we are not ready for infectious pathogens that come from all over the world or from in the United States. We had taken some public policy steps to create pandemic response or disaster preparedness response, particularly infectious diseases. That was not effective in this, and we were not ready to do what was necessary for basic interventions like cloth face coverings or assuring adequate PPE for health providers, much less understanding treatment models or potential therapeutics. And so we need to rebuild what we know about basics of infection control and prevention, and to build an infrastructure of pandemic preparedness or epidemic preparedness so that we don't get caught in this situation again, where 7, 8, 9 months into this, we still don't have a national testing strategy. We still don't have a clear understanding of how we're doing contact tracing and basic epidemiological strategies to stamp out infectious diseases. We have a lot of work to get through this pandemic and then rebuild an infrastructure. Part of that infrastructure, of course, is rebuilding public health. We know that public health funding has gone down and down and down over the years, and so public health departments are not ready for this moment. AAP for the last several months has been gathering directly from public health departments whatever they are releasing publicly on child health surveillance for COVID-19. And there are states that we just don't have because they are still operating on fax machine based case reports. So someone is faxing a case into a public health department. That fax is received, put in a box, and stacked up in the corner, waiting for someone to data entry that into a computer one at a time. I mean, we're not ready. And so we need massive new investments in public health in order to make public health departments at the county level and at the state level work together and align with the Centers for Disease Control, so we have a much better picture of what's going on across the country. And then we need to figure out how to align all that public health, community-based interventions, data, and pay for that, so that financing drives the kind of care that we want, or care that's based on value and not volume, care that's based on outcome and not the number of kids seen, how fast and how much during the year. And so value-based payment models need to be developed, and they need to be developed with children in mind, not retrofitted from an adult model. And that brings me to the last point of this going around the wheel here, is that every community is different. Every community of children is different and needs different things. What may be needed in native lands is very different than what might be needed in the inner city. What may be needed in a rural community is very different than what is needed in a suburb. And so our models of care have to be much more flexible and responsive than they are right now. Not one size does not fit all for pediatrics, certainly, and that's true of location and geography, of community that you're serving, and then developmentally across the lifespan of children. Adolescents need different things than the newborn does, and certainly young adults and beyond. So I think if we can think through a urgency around connecting issues of the election to our vision of what the future of pediatric practice is post-pandemic, and then be prepared to hold policymakers and others highly accountable for what we believe is the best thing to take care of children, there is optimism here. there is an opportunity to make a real difference in the future. We have to be ready to describe that, assuming that the political opportunities exist. Julius Richmond, who was a former Surgeon General of the United States and a pediatrician, used to always say, chance favors the prepared mind. And so, if we have an opportunity to be with a policymaker who wants to help us rebuild a new system, we have to be ready to articulate what that is. That's true of AAP at the national level, and it's certainly true of AAP in Washington State. And your chapter is doing this work right now. As I mentioned, there is a workshop tonight talking about the 2021 legislative proposals. So if we can create a political environment to move forward, I think we can address some of these issues, but the stakes have never been higher, and it is crucially important that we do it. This is a screenshot of Dr. Sally Goza's Twitter handle page. This is art that we have on Vote Kids website, and it says, "I vote kids because their future depends on it." And that is the energy that drives us to produce the materials that we can for kids, and to try to get out the vote. This is an incredibly important election. It is not just a presidential election. Governors are being elected. The United States Senate, a third, is being elected. All of the United States House of Representatives, state legislatures across the country. And so, as we hold kids up in our minds and in our hearts and think about what we want and know is best for them, this is a powerful moment in the election. Later today, I'll break some news here. Later today, the AAP will be releasing the 2020 version of the blueprint. This is the document I referenced at the beginning that we released in 2016. It is an updated version of that. It's going to be entirely online. All members of the AAP will get a message from Dr. Goza later today with that. I encourage everyone to read the blueprint. It is a granular approach to the buckets that I described earlier in what's at stake in the election. And most importantly, it gives a clear understanding of what we think needs to happen. And if a policymaker wants to know what AAP thinks about what should happen in a particular area, all they have to do is go to the blueprint. And that's incredibly important for the future. I'm happy to be with you this morning. I'm happy to take your questions, and I encourage you to get out there and vote. Make sure that the residents vote. Make sure that the fellows vote. Talk to your patients when you can. Particularly, I keep hearing great and exciting stories of 18-year-olds, and this is their first election. And isn't that exciting to be voting in such a consequential election? So thank you, Dr. Harding Walker, for the invitation, and I'm happy to take some questions if you have them and engage in some discussion. Thank you very much.
Thank you. And everyone, feel free to type your questions into the chat, and I believe Mark is able to see them. And
Thank
you
you.
can unmute at that time if you want to talk.
I can already comment. I see Dr. Shaquita Bell in the chat box there. Dr. Bell, thank you, first of all, for taking your time to join today. And thank you for everything that you are doing for the Academy of Pediatrics. You have given so much of your time, talent, and expertise to the AAP and your leadership. So thank you for what you're doing. And I appreciate the comment that you put in the chat box. I didn't mention the AAP's Truth, Reconciliation, and Transformation Statement. But I probably should have at the end of July, we did issue a statement apologizing to 2 Black members who were delayed admission as members of the Academy in the 30s because they were Black, and for no other reason than that racist motive. And the Academy called that out, spoke about it specifically, and published an apology to those 2 physicians, and committed ourselves down a path to do it differently. And so I encourage folks, if you're interested, to read that statement. It's available easily for you. Thank you. There's a question about residents and fellows getting involved. One of the parts of being virtual that's challenging is that I don't get to see the residents. I always know them because they're in the back row of whatever auditorium I'm giving grand rounds in. And so you can go find them. The medical students are in the front row. The residents are typically in the back row, and then community physicians and faculty and fellows are in the center. So speaking back to you, residents and fellows there, in the same way that advocacy it has been a part of the DNA, literally part of the founding of the American Academy of Pediatrics since 1930, I encourage you to really think that the implication of that is that advocacy is in the DNA of pediatrics, period. And that what advocacy means, what being a pediatrician means, is to be an advocate for children. And that thinking about that as part of the work from the very beginning will enrich your career and broaden your impact and give you the chance to do some very exciting things. As pediatricians, and anyone who works for children, really, you're an advocate by definition, whether it's getting the child the test they need or getting that prior authorization um, from an insurance company. There's advocacy moments all the time. And so thinking about yourself as an advocate from the very beginning means that you don't have to do anything to become an advocate. You already are an advocate. And if you're interested in doing more advocacy outside of the institution or in the community or at the state or certainly at the federal level, there are lots of resources available to help you and support you in those efforts. Think carefully about what it is that you want to change and who you want to work with. Find some partners and jump in. Get started. Think about advocacy as something that you just do as part of your everyday work. The section on trainees for AAP has very developed resources for you, for fellows and residents to help you get involved and skills training and practical tools and all of that. So check out the section's website on aap.org to get involved in there. There is trainee representatives in all of pediatric programs. And so find out who that person is and get that door open to the AAP to get you involved in training and in advocacy in whatever layer that you want to and whatever energy you feel that you have to be a part of it. And think about advocacy in the way that you think about engaging families. I always say that pediatricians make great advocates, and they make actually great media spokespersons as well, because they are very accustomed to taking difficult concepts, sometimes very emotionally fraught concepts, very hard work, and translating that and explaining it to families. And so you take all the expertise and the medical knowledge that you have and the diagnosis that you're making, which could be very challenging and scary, and sharing that information in a way that families can receive it, take it in, and understand what they need to do next. If you use that paradigm when you're thinking about policymakers or the media, you know, explain in a careful, simple way the important issues that are going on and what it means for a child or children, then you already have everything you need to be an effective advocate. So for the residents and fellows, get involved in the section. For the fellows who are entering a subspecialty, please get involved in the subspecialty section of the AAP. There are lots of mentors and people who are thrilled to be helping out and bringing young members of the subspecialty into practice. And there's lots of people who want to step forward and help you do that. So my biggest advice to you, in addition to everything else, is go find some mentors and friends who care about the things that you care about and want to help you be successful as an advocate. Welcome aboard. We need you desperately. You'll be, especially for the residents and fellows, you'll be architecting this new healthcare system. You'll be architecting this new future of healthcare. You'll be a transformational bunch. And so embrace that and get excited about it. And we're eager to hear from you. Dr. Cooker, excited to see the new blueprint. It has been refreshing to have AAP's strong voice during these turbulent times. Thank you very much. We appreciate that, and we need to keep hearing from you as well. Very, very important. Uh, Next challenge to the ACA: how is AAP thinking about addressing threats to child and adolescent health care coverage? Oh, yeah, this is a tough one. So I can give a little bit of background. The question about whether or not the Affordable Care Act will be struck down by the Supreme Court is a legal question, actually more than a political one, and it turns on legal issues of severability, which, as a lawyer myself, those are quite interesting topics to think about. Arcane issues of whether or not, if one piece of a law is unconstitutional, is the whole law unconstitutional, or just that piece of the law? And that's all stuff that lawyers like to think about. And it was quite impressive to see, in the context of a judicial confirmation hearing for a justice of the Supreme Court, extensive questioning about the justices or potential justices' views on severability. That used to be kind of inside baseball for lawyers, but now everybody knows about it. So the question about the Affordable Care Act in the Supreme Court will turn on kind of a novel and very legalistic issue about what part of the law is constitutional or isn't. But what I often say about the Affordable Care Act is that trying to take the Affordable Care Act out of the healthcare system is like taking the eggs out of a cake. It is just not possible anymore. That over the last 10 years, the Affordable Care Act and all of the things that were built through it and by it have infused its way into the healthcare system. So it's too simplistic just to talk about the healthcare exchanges or Obamacare as an access to subsidized health insurance through state-based exchanges, whether there's an individual mandate or not, or whether you access it through a public option or something like that. I think the more important question is, for the next administration, either a second Trump term or a Biden term, what do we do about the rising rates of uninsurance in the United States? And what do we do about an increasingly unworkable employer-based health insurance system in the US? We have a very unusual thing as far as a Western democracy goes, that we have an employer-based health insurance benefit system. And that creates all kinds of the challenges and discussion and difficulties that I described when we were looking at the wheel. It's just not working in very well. And so the policy challenge before us is, what do we do about the uninsured? There are too many children who have no insurance or who are underinsured. And there are too many adults that are uninsured or underinsured, and that creates uncompensated care that distorts the financing of healthcare systems and results in excess morbidity and mortality. So I think the policy question for us is, if we all have the shared goal of universal access to care, then we have to figure out, how do you finance that? And do you finance that in the private sector or the public sector, or some combination of the two? And I think that's a much more interesting conversation and a much more important conversation than whether it's Medicare for all or socialized message. The political fights get reductive and unhelpful. But the policy question really is, in places where the private market just doesn't work, what do you do for those folks who don't have access to health insurance? And if they don't have access to health insurance, how do you compensate for that so that it doesn't force people who are covered to subsidize the uninsured and create higher cost drivers for that? So this is important stuff, and I think the pediatric piece of it is crucially important, especially when we were very close to eliminating uninsurance in children. We were at 95% coverage for kids under 18. That number is ticking back up, sadly, but we were almost there through Medicaid and CHIP and private insurance, and we got to get that curve back down to zero as much as we can. Thanks for putting the link to the Washington chapter event tonight. That's great. I hope people have time to do that. I should have addressed that. Obviously, the nomenclature of the charter is uncomfortable today, and is not obviously something that we would support going forward. And so, yes, absolutely. And thank you for reminding me to point that out. If you look at the demographics of children, and if you look at the demographics of pediatrician, there is no the women. The default pronoun should be feminine at this point. So we are not finished as we grapple with structural racism and institutional bias in gender bias issues as well. And so that is crucially important. And I thank you for the opportunity to address that.
Thank you so much. Thanks for your advocacy and all your work with the AAP. It's really great to see this long history of advocacy and all the ongoing work that's still happening. So we really appreciate you being here. And thanks everyone else for tuning in. Have a great day, and we really appreciate, and everyone remember to vote.
Vote.
Thanks.
Thank you, everyone. Bye bye, everybody.